Hi everyone. In this video, we are going to see about the breech presentation. Breech presentation is a presentation in which the fetus is in longitudinal lie and the buttocks is the lowermost part. So the lie of the baby will be longitudinal, and instead of the cephalic presentation or instead of the head coming into the lower segment of the uterus, here the buttocks will be coming to the lower segment of the uterus. And the incidence is before 20th week, you can see the breech presentation in 25% of all the pregnancy. And at term, you can see it in the case of only 2 to 3% of all pregnancy. 2 to 3% of all pregnancies, you can see the breech presentation. Next is classification of the breech. It can be classified into frank breech, complete breech, footling breech, and knee presentation. Frank breech means where the hips are flexed and the legs are extended. You can see it in the case of 65%. And complete breech where the hips and knees are flexed and the feet are not below the level of the buttocks. Footling breech is the one where both feet are presenting and these will be lower than the buttocks. And in the case of knee presentation, knees are the lowermost presenting part, hips are extended and the knees are flexed. See, this is the frank breech. Here you just see the hips are flexed and the knees are extended and buttocks is in the lowermost part. And here this is the complete breech. In complete breech, both hips are flexed and the knees are also flexed, and buttocks here also the buttocks will be in the lower pole of the or in the lowermost part of the uterus. And footling breech means here the hips are extended and the knees are also extended and the foot will be below the level of the buttocks. This is the knee presentation. Here hips are extended, sometimes one or both hips are extended and the knees are flexed. So these are the types of breech presentation. Now we can see the different positions in breech presentation. In the breech presentation, the denominator is sacrum. The denominator is sacrum, and if the sacrum is pointing towards the left iliopectineal eminence, the position is left sacro-anterior or LSA. If the sacrum is pointing towards the right iliopectineal eminence, the position is right sacro-anterior or RSA. If the sacrum is pointing towards the iliopectineal line, right side iliopectineal line, it is right sacrolateral. If the sacrum is pointing towards the left side iliopectineal line, it is left sacrolateral, LSL, right sacrolateral, RSL. If the sacrum is pointing towards the right sacroiliac joint, it is right sacroposterior, RSP. If the sacrum is pointing towards the left iliopectineal eminence, it is left sacroposterior or LSP. These are the different positions on the basis of the denominator in the case of breech presentation. Now we can see the causes of breech presentation. First one is the maternal factors include polyhydramnios, that is, if more amniotic fluid is there means more space will be there inside the uterine cavity, so the baby will be moving in and around and there's a chance for occupying or coming to the lower pole of the uterus, that is buttocks may come to the lower pole of the uterus and it may occupy the lower segment. And in the case of oligohydramnios, already if the baby is with breech presentation, later because of the less available space, baby may not get a chance to go back to the cephalic presentation. And the uterine abnormalities like biponoate uterus and septate uterus. That is, if a septum is there or if a septum is separating the uterus into two segments, Because of the less availability of the space, the buttocks may come to the lower pole of the uterus. And in the case of biconate uterus, in that case also, the upper segment will be like two cornea will be there in the upper segment. So there, in that case also, less space will be there in the upper segment. And space occupying lesions, for example, fibroids of the uterus, placental abnormalities like placenta previa, coronal placenta, all those things, and multiparity, especially in the case of grand multipara. Here also excessive laxity of the abdominal muscles will be there, so the baby will be moving very freely. So there is a chance for occupying the lower segment. And next one is contracted pelvis. In the case of contracted pelvis, when the head is coming downward, less space will be there due to the small pelvis. So naturally, the bitrochanteric diameter, that is the diameter of presenting diameter in the case of breech presentation, that may come and occupy the lower pole of the uterus. Next one is fetal factors, prematurity. In the case of premature baby also, the size will be the problem. The baby will be moving and more space will be there for the baby because of the less size of the baby. And fetal abnormalities like neurological abnormalities of the baby like anencephaly and hydrocephalus. In these two cases also, there is a chance for breech pregnancy. And next is multiple pregnancy. In case of multiple pregnancy, if one baby is in the normal position, the other baby may come to the breech presentation. Next cause is fetal death. In the case of dead baby and premature baby, laxity of the muscles, flaccid muscles will be there. So the neck may get extended, and sometimes the position also of the baby also may get changed. And short umbilical cord. If the length of the umbilical cord is less, usually, and if the placenta is in the lower segment, along with that short placenta, the buttocks also will come to the lower pole of the uterus. And extended legs, because they splint the trunk, and so it interferes with the spontaneous cephalic portion, so there is a chance for breech presentation in that case also. Next, let us see how to diagnose the breech presentation. It can be done by the clinical examination, that is by the abdominal examination and by the vaginal examination, and you can go for the radiological examination like X-ray, ultrasonography, CT scan, MRI, all those things. First, let us see about the abdominal examination. In the abdominal palpation, in the fundal palpation, usually if it is a cephalic presentation, you will be getting broad, soft, irregular mass in the uterine fundus. But here, instead of that, you will get hard globular mass in the fundal palpation. Hard globular mass suggestive of fetal head in the case of fundal palpation. And in the case of pelvic palpation, you will be getting soft, broad, irregular mass suggestive of the fetal buttocks. And if you are going for the auscultation, the fetal heart sounds. In the case of cephalic presentation, usually you will be able to hear the fetal heart sound at the lower pole, that is below the level of the umbilicus. But here, in the case of breech presentation, you will be getting the fetal heart sound at or above the level of the umbilicus. Next, on the vaginal examination, the buttocks is not a well-fitted presenting part. So you can see the slow dilatation of the cervix, and once if the membranes are ruptured, the presenting part can be felt. So you can feel the buttocks and you can feel even the anus also, and the genitalia on one side and the sacral spines on the opposite side. In case of complete breech, the feet are felt on the same level of the buttocks. Foot also will be able to feel at the same level of the buttocks. And in the case of breech with extended legs, the buttocks only can be felt. In case of footling presentation, the feet are at the lower level than the buttocks. So in that case, you will be able to feel the feet. In the case of knee presentation, the knees will be at the lower level than the buttocks, so you will be able to feel the knees. And when you are palpating the foot, sometimes you may mistaken it as hands. In that case, what you can see means you can just try for the opposition of the great toe. If it is a finger, opposition of the fingers will be possible. But in the case of leg, it's not possible. And the fingers of the toe or the toes will be in almost similar line. almost same length will be there for the toes. And if you are able to palpate the foot, actually there is no similar portion for the hands, same as like foot. So these are the things you can identify in the vaginal examination. Next, in the ultrasonography, you can if you are taking CT or if you are taking the MRI, you can confirm the position of the baby. See, this picture shows the ultrasonography of a breech presentation. Next, we can see the management of breech presentation. After 36 weeks, sometimes spontaneously version or change of position of the baby will occur. Otherwise, you can go for the external cephalic version or internal cephalic version. And management of the breech presentation. If the breech presentation is persisting, if it is continuing even after 34 weeks of pregnancy, you should take an ultrasonography and you should exclude the fetal abnormalities, polyhydramnios, placenta previa. And once if 37 weeks are completed, you can try for the external cephalic version. See, the version means it is bringing back the baby to the normal cephalic presentation. If you are performing it externally, it is known as external cephalic version, or if you are introducing one hand into the vagina and if you are doing it, it is known as internal cephalic or internal podalic version. So two versions are there, external cephalic and internal podalic version. And this picture shows the external cephalic version. See here the baby is in the buttocks presentation by applying pressure in the opposite direction. See here by using this hand the examiner is applying pressure over the buttocks towards upward, and by using this hand the examiner is applying pressure downward over the head, and finally because of that pressure the baby is coming to the cephalic presentation. And this is actually the external version or external cephalic version. Next, we can see how to perform the external cephalic version. It should be done in the labor room, and you are supposed to keep the mother nil orally, because in case if the version fails, immediately you are supposed to take the baby take the mother for the cesarean section. Version fails in the sense sometimes once after changing the baby may go back to the same breech presentation. Otherwise, when you are turning, there is a chance for complications. That is, there is a chance for separation of the placenta. If such complications are occurring, immediately you are supposed to go for the cesarean section. So you are supposed to keep the mother nil orally. And you should take the continuous cardiotocography, ultrasonography also if it is possible you can take, and give a tocolytic drug. Tocolytic is a drug means what is the action of the tocolytic drug? It's a drug which produce or which act against the uterine contraction. So once when you are performing the version or manipulative procedure, it may stimulate the uterine contraction and there is a chance for onset of labor. So for preventing that, give a dose of tocolytic and give a head down position for the mother and just dislodge the breech if it is slightly entered into the pelvis, just dislodge it from there and gently turn around it. And you should, when you are doing this also, you should monitor the fetal heart sound. Cardiotocography should be taken. Even if it is uterus, even if the uterus is contracting also, you should see the relationship between the contraction and the fetal heart rate. If variations are there or if signs of fetal distress is there, in that case also you should take the mother for the cesarean. See here, you can see the exact picture. Here they are mobilizing the breech from the pelvis and manually they are rotating the breech. See here they are pushing the breech upward, at the same time they are bringing the hand, bringing the head downward, and here the complete rollover or complete change of position has occurred over here. Next is internal podalic version. Here also the procedure is almost same, but instead of keeping both the hands over the abdomen, here one hand will be introducing through the vagina and that hand will be pushing the buttocks upward and the other hand externally will be keeping over the abdomen and that will be bringing the head downward. And next we can see the risk or complications of external cephalic version. When you're performing it, there is a chance for separation of the placenta or placental abruption. There is a chance for premature rupture of the membrane, and sometimes cord may get separated, and there is a chance for transplacental hemorrhage. That is, there is a chance for bleeding from the placenta or to the baby. So in the case of RH negative mothers, there is a chance for anti-D formation, and reagents may form inside the baby's body against the blood, and there is a chance for fetal bradycardia, and fetal hypoxia is also there if placental abruption is there, or if other cord damage or something is happening, there is a chance for fetal asphyxia also. Next, contraindications of the external cephalic version. The contraindications are absolute contraindications are there, and relative contraindications are also there. The absolute contraindications include previous cesarean section or previous scar over the uterus, placenta previa, and if antepartum hemorrhage is there, if the mother is having pre-eclampsia, if multiple pregnancy is there, in that case surely you are not supposed to go for the version. And relative contraindications include RH isoimmunization, elderly primigravida mother, intrauterine growth retardation, oligohydramnios, and polyhydramnios. In all these cases, if you are going for the version, there is a chance for getting complications either for the mother or for the baby. Next, management during labor. If complications are there, you can try for the cesarean section if the pelvis is not adequate, or if the size of the baby is more, or if the mother is having other complications, if the mother is an elderly primigravida, if the mother is having eclampsia. In such cases, you can go for the cesarean section. Otherwise, you can try for the normal vaginal delivery. It can be a spontaneous breech delivery, or maybe an assisted breech delivery, or maybe a total breech extraction. Spontaneous breech delivery means the delivery will occur without any assistance. Assisted means it needs slight assistance, and total breech extraction means completely without assistance we will be taking the baby out. And next we can see the indications for the vaginal delivery. If frank or complete breech presentation is there, and if the gestational age is more than 36 weeks, if the weight of the baby is between 2.5 to 3.5 kg, and fetal head must be flexed, and maternal pelvis should be adequate for confirming that you can take an X-ray of the pelvis, and there should not be other complications like already I have told you, maternal diabetes, large baby, eclampsia, antepartum hemorrhage. Such complications should not be there. And once if the labor process has started, you should see for the full dilatation of the cervix. Already I have told you, you should assess the capacity of the pelvis. You should empty the bladder and bowel. You are supposed to give proper explanation and support to the mother and family. And when you are before starting the delivery itself, you should make arrangements for the newborn resuscitation. And when you are performing it, you should make sure the availability of physician, anesthetist, and pediatrician over there. And next is partial breech extraction or assisted breech delivery. Usually first the delivery of the baby will be occurring in 3 steps. First delivery of the buttocks will occur, next delivery of the shoulder will occur. Once if the delivery of the buttocks has occurred, it is better for the midwife to cover the baby or wrap that buttocks by using a clean cloth, so that it will be easy for the midwife to hold the baby, so that that slippery movement will not occur, and at the same time it will provide warmth for the baby. And later you should make sure slowly the delivery of the shoulder will occur. Once after the delivery of the shoulder, sometimes the head may get stuck over there, or it may remain over there. In that case, you can try for different methods to delivery of the aftercoming head. In that, first one is Burns-Marshall method, and second one is Mauriceau-Smellie-Veit Maneuver, and other one is application of the forceps. This third one we are not using commonly. See, this is Burns-Marshall method. You just see this picture. Here delivery of the buttocks and shoulder has occurred already, and head is inside the pelvis and the back is uppermost. What you are supposed to do means the examiner or the nurse should hold the fetal leg by inserting one finger in between the two legs, and by holding that, gradually you should rotate the leg upward. See here, you're just rotating the baby upward, and when you're rotating, you should make sure that you're not flexing the spine. At the same time, for ensuring the flexion of the head, you can apply pressure by using the other hand. You can apply pressure over the occipital region, so that may make sure the proper flexion of the head. So this movement may dislodge the head from there. Once if the face has come out, you can aspirate the mouth and nose passages, and later by turning the baby upward towards the mother's abdomen, you can ensure the delivery, or you can deliver the impacted head. This is the Burns-Marshall method. And next one is Mauriceau-Smellie-Veit Maneuver. In that case, the examiner, by using the left hand, the examiner is supposed to hold the baby like this. This left hand, the examiner is holding the baby on its chest and abdomen, and the two fingers of this left hand should be placed over the baby's mouth. See here, it is in the baby's mouth, and the other hand, the right hand, the examiner can place over the back of the baby, and by using the fingers of that hand, the examiner should apply pressure over the occipital region. So this pressure will help for the flexion of the occiput, and at the same time, by using these fingers also, you can ensure the flexion of, see, already I have told you that two fingers should be inserted into the mouth, and by using those two fingers, they can flex the baby's head downward. So by using this upper and lower pressure, it will flex the baby, and when the head is getting flexed, the head will get dislodged from the pelvis. And this is Mauriceau-Smellie-Veit Maneuver. And next one is Piper forceps. If the head is impacted over there, you can apply the forceps, and by using the forceps, you can ensure the delivery of the baby. And total breech extraction, that is, if the labor is getting prolonged, if twins are there, if maternal diseases are there, if cord prolapse is there, or if signs of fetal distress is there, in that cases you can go for the total breech extraction. See, from the beginning it onwards, you are giving support for the delivery process. When the leg is coming, you are just applying slight pull over the leg, and when the buttocks is coming, you are just helping for the rotation of the buttocks, that is restitution and other rotation of the buttocks by using both hands. And once if the buttocks has delivered, the nurse is supporting for the delivery of the shoulder by changing the position of the baby, and finally for the delivery of the head also, for the complete process, support will be giving. Next, if these things fails, you can go for the cesarean section. Now we can see the indications of the cesarean. If the fetus is large, if contraction is there for the pelvis, or if the shape of the pelvis is not favorable, if it is not a normal gynecoid pelvis, if head is hyperextended, if uterine dysfunctions are there, if the uterus is not contracting effectively, if incomplete or footling presentation is there, and in the case of primary gravida mothers, you can go for the cesarean section. Or if healthy preterm, if the baby is a preterm baby, if there is severe growth retardation, intrauterine growth retardation is there for the baby, and if there is previous history of perinatal death or death of the newborn is there, and complications of birth trauma is there, or if an experienced operator is there, if the nurse or doctor is not confident, in that cases also you can go for the cesarean. And complications of breech delivery. It includes maternal complications and fetal complications. The maternal complications include chance for operative interventions, chance for infection due to the manipulations, intrauterine maneuvers, that is, when you are doing the external cephalic version or version, there is a chance for rupture of the uterus, and there is a chance for lacerations of the cervix, chance for extension of episiotomy, Due to the prolonged labor, there is a chance for uterine inertia, uterine atony, and due to the prolonged labor and the uterine inertia, there is a chance for postpartum hemorrhage. And the fetal complications include chance for preterm delivery, there is a chance for prolapse of the cord, chance for birth asphyxia due to the prolonged labor, chance for fetal injuries, that is there is a chance for fracture of the humerus, clavicle, femur, chance for brachial plexus damage and that may produce Erb's palsy, chance for skull fracture, intracerebral injury, and when you are holding the, see in the complete breech extraction you have seen that the nurse or the doctor will be holding the baby over the buttocks, over the abdomen like that. So when you are holding the baby or grasping the baby, there is a chance for damage to the liver, spleen and adrenal, and there is a chance for spinal cord damage also. So that's all about the breech presentation. So we have seen the causes, management, all those things are about the breech presentation. And next video we will be meeting again with the mechanism of breech presentation. Thank you for watching the video. Thank you so much.